Okay, everyone, I hope everyone's doing well today. My name is Bill Croft. I'm with the North Carolina Respiratory Care Board, and I am the Executive Director. What I'm here today to talk to you about is pushing the boundaries, advancing respiratory therapy practice, and professional advocacy. Sometimes this thing does not want to move when I am presenting with slide share. Hold on, there we go. Okay, so just to disclosure, I do represent the North Carolina Respiratory Care Board as the Executive Director, Rules Coordinator, Legislative Liaison. I also serve as a consultant for the NBRC and as a co-chair for the APRT committee with the AARC. I just recognize all of these roles because a lot of the things that I'm going to talk to you today will sort of intertwine, and I want to make sure that you know who I'm representing at this time. I'm not representing the NBRC or the AARC. A couple of creative works disclosures. I either own, myself personally, developed, or the board owns the creative works within this presentation, or they're part of the subscription to the AI platform that I have that I'm using. It's called Beautiful AI. What you will be doing today and hopefully gaining from it is an understanding of the scope of practice and the relationship between professional credentialing and regulatory agencies, and discuss the factors influencing the scope of practice in the future. Now, I know this is about advocacy, so I'm going to get to that in just a second. But let me give you a few things that you need to be aware of. First, what is the board mission? Well, most people would sometimes say, well, it's to protect our profession. Technically, it's not. It's to protect the public from unqualified practice of respiratory care and unprofessional conduct by persons licensed pursuant to this article, and that article is 38. So in some ways, not in some ways, by requiring competency and preventing unprofessional conduct, that's the way we advocate for the profession. And that's really important. That's why we have licensure. You're in a unique position because this past July, as you got transitioned into the second year, we crossed the threshold of 25 years licensure in North Carolina. So we're very proud of what we've done since we became licensed in North Carolina. And matter of fact, North Carolina leads the nation in very progressive approaches to scope of practice. So what you need to first understand is what is the Practice Act? What is our scope of practice? What are the regulatory oversight issues that you need to be aware of, and how is all that interplay? And then the facility requirements. Again, what does that have to do with advocacy? It has everything to do with advocacy. If you are going to be an advocate for the profession, you want to have to really understand all of these things, because you can't just advocate. I guess some people might think of it as like a cheerleader. No, a cheerleader is not an advocate. An advocate is someone who can speak fluently about the profession, and to speak fluently about the profession and to be able to sway others either to come into the profession or to understand your value as a professional. You have to be knowledgeable, and part of that knowledge not just comes from what you have, what you can do at the bedside, but how do you, as a professional, how are you rounded out? Understanding the laws and all of the different laws and policies and procedures that impact you are extremely important as part of your advocacy. You can be the smartest person in the world in terms of providing bedside care, and as long as you stick to that, you'll be a great advocate. But to be even a better advocate, understand how everything comes and plays together, because that way you'll be able to really sway people over to, hey, respiratory therapy is a profession that's worthy of recognition and worthy of being paid at our highest rate and worthy of being included in the care team. We are part of the care team, and by one of the ways you can advocate is to be a very good member of a care team. That means playing as a team, and to play as a team, you have to understand how all of the policies and procedures and statutes and rules all kind of play together. So we'll begin sort of with the end in mind, if you will. Here's what happens when somebody's as an advocate. Okay, as an advocate, let's talk about how that happens. And it may be as simple as asking the question, can a respiratory therapist do ECMO, or can a respiratory therapist do PICC lines? Can they do or perform conscious sedation? If you called the board years ago and asked that question, one of those questions, you would be advocating for the profession in one way, because you're asking questions, you're being inquisitive, you're seeking out new knowledge and new procedures in this case, as to whether the board sees it as part of your practice. And then by doing that, the board will be able to look at it through the eyes of the statute, the Practice Act, our board rules, which define the Practice Act, previous rulings, AARC documents, such as clinical practice guidelines, position statements, white papers, NBRC testing matrix, because that actually is what measures or helps us measure your competency, and the COARC standards. How does your education fit into this picture? What do they say is within your scope, and how are you trained, and how we can verify that? The Department of Health and Human Services rules in North Carolina also help us define your rules that they have related to respiratory care services, which also come into play. All of these things are considered when those questions are asked to come to a final decision. So it's usually always a manager, a respiratory therapist that asks the question, but sometimes it's a nurse manager or a nursing supervisor that asks the question. And by by asking us stimulating questions, we take that up, determine whether or not it can be a respiratory therapist can practice whatever procedure they're asking about, and then it actually becomes part of the scope of practice. We have to justify it. That's our job. We have to justify it in statute, in rules, and base it upon all these other things that I just mentioned. So the Respiratory Care Practice Act is the law. It's Article 38. Also, again, it's GS 90-647. It was actually implemented in 2001 after it passed in 2000. It was July 13th, 2000 at 3 o'clock in the afternoon when the law was passed. It was later signed into law by Governor Hunt about a month later, I believe. And then we officially began licensing people in 2001. So technically, you could say 2000, this year's 25 or next year's 25, but we're going to say this year's 25 because that's when the Practice Act actually passed. But what does it do? It protects the public from unqualified practice and ensures a minimum standard of competency. That means we require education, we require credentials, we require ongoing education to help do that. Now, there's a definition within the statute that says, and definitions are probably one of the more important areas of a Practice Act you need to pay attention to, because that lays the framework for a lot of things. Sometimes people say, well, there's definitions, but they actually say a lot more than you would imagine. For example, the practice of respiratory care is defined by the written order of a physician licensed under Article 1 of this chapter. Okay, so we follow in the chapter that we're talking about, Article 1 within the chapter of statutes in North Carolina is the Medical Practice Act. So we fall under the physician's orders. That means everything we do, the observing, monitoring signs, symptoms, general behavior, general physical response to respiratory care treatments, diagnostic testing, including the determination of those signs, symptoms, reactions, behavior, or general response exhibit abnormal characteristics, and of course the performance of diagnostic testing and therapeutic applications are all because of an order. So in other words, when the physician writes an order to do aerosol therapy, yes, it's an order for aerosol therapy, but you're also doing all these other things when he orders that or she orders that. There are some specific things that obviously you would imagine that we would do that are listed, actually listed within the statute: assessment, diagnostic testing, medication administration, mechanical ventilatory support, physiological ventilatory support, CPR, cardiopulmonary rehabilitation, I don't have CPR there, medical gas delivery, hyperbaric oxygen therapy, and verbal orders. So these things are very specifically mentioned, but in a generic way. For example, we do not list any particular medication, but it does say medications related to the cardiopulmonary system. That's a big category. It talks about diagnostic testing, but again, it doesn't list specific diagnostic testing. It does list sleep studies and it lists a couple of other things, but it's very broad because I'll show you in just a minute why it's so broad. But of course, assessment is listed because that's part of what we do. But again, it's not limited only to assessment of the respiratory system, if you know what I mean. It's much more broad than that. The only thing that's really specific is hyperbaric oxygen therapy for some reason. And but that, I say for some reason, I know the reason. It goes back to the creation of the law and the need to have that explicitly worded in there. But you won't find necessarily, you won't find albuterol, you won't find any of the medications that we deliver listed in the statute or the rules. So for example, ECMO, conscious sedation, air transport, ground transport, airway clearance, patient education, disease management, cardiac stress testing, triage, and vascular line placement. None of these things are mentioned. But guess where they are mentioned and where they are located? They're located in the clinical practice guidelines of the AARC. And of course, they're also in the position statements and white papers that are within the AARC's guiding us. And they're also in other guidance documents beyond the AARC. So when we talk about the scope of practice, we have to step back for just a minute and ask ourselves, does it fall within the practice of respiratory therapy, or does it fall within the practice of cardiopulmonary medicine and our cardiopulmonary disease, if you will? Because actually, our law doesn't mention respiratory therapy as much as it does cardiopulmonary physiology or cardiopulmonary disease. So we're very much more than respiratory therapists. We are cardiopulmonary therapists, if you will, because we're treating the heart and the lungs. So let's get into the rules. So the rules further define the scope within a definition. Again, definitions are really important. So if you go to the rules and you go to the definitions, that's where you want to spend some time. The practice of respiratory care means the performance of assessments and diagnostic tests and implementation of treatment procedures and protocols related to the cardiopulmonary system pursuant to this paragraph, 90-648, paragraph 10, and the activities defined by the American Association for Respiratory Care clinical guidelines, incorporated by reference, including subsequent amendments and additions. Very important because it says pursuant to 90-64810F, which I'm going to get to in just a moment. But bottom line is this. The definition of what we do is focused in on cardiopulmonary system. That means cardiopulmonary disease. That means treating the heart and the lungs, not just the lungs. So what does that one paragraph or subparagraph say? New and innovative respiratory care and related support activities in appropriately identified environments and under the training and practice guidelines established by the American Association for Respiratory Care. Extremely important because if you think about it, there's no way we could build into any law the future. This did that for us. In other words, as the AARC grew over the last 25 years, so did our scope. If we did not have this in here, like a lot of states don't have this, they would have to amend their Practice Act just to get a new procedure put into their list of things that they could do. That creates a lot of angst for people. We have never had to do that because of this one subparagraph. So let's talk about protocols, because protocols are sort of the bane of my existence, not because I dislike them, but because I commonly get calls that Joint Commission reviewer says that respiratory therapists can't do protocols because it's not within the scope of practice. Well, it's not stated in the Practice Act, so we put it in the rules, but also it is stated by the AARC and it is stated by the NBRC and COARC. So we've got a strong legal basis for saying within our Practice Act, we have the legitimate authority to do protocols. So keep that in mind. This is why it's so important to understand when, your scope, but also how your scope interplays with other laws and other agencies. So let's talk a little bit about American Association for Respiratory Care. If you're not an AARC member, I would highly encourage it. Everything I just mentioned, from our licensing act to all the rules and guidelines and clinical documents that we've produced, come from what we can gather from the AARC in cooperation with our law or within coordination within our law, such as promoting respiratory care standards, which is probably the most important part for me, along with clinical practice guidelines. The research is necessary to support those two things. but also then to continue promoting continuing education, because for you as a practitioner to be competent, you need to actually continue your education. You can't just sit back and say, well, I've learned everything I know, that I need to know, so I'm going to stop here. No, don't do that. It's really important to make sure that you continue your education as you graduate next year. There's some things you need to know about the AARC. They're not just doing those things. They're also funding respiratory profession post-COVID with $5 million. They're doing education and development with AARC University. If you're a member, you have access to webcasts and clinical practice guidelines. You can get involved with emerging leaders programs if you want to later on. Publications and research that you have access to, but also they help their advocacy for their state. Advocacy and state support is extremely important, both on the federal and the state level. But the clinical practice guidelines are probably, to me, one of the greatest things that they do, because it takes a lot of work, but it's so helpful in helping grow in our profession. All of that the AARC does has led to not just a few, actually all of our declaratory rulings. These are just some of the top rulings that we were able to pass as a result of what the AARC said that's within the scope of practice of respiratory therapy. The critical care transport and ground transport, conscious sedation and drug administration. So this is, during conscious sedation maneuvers, you can actually administer the drug, not just do the procedure. ECMO and CRRT, which is, of course, continuous renal replacement therapy along with ECMO. Patient education and disease management, as well as advanced respiratory care practitioner. These are just a small sampling of some of the rulings that have come out of that research, clinical practice guidelines that the AARC has provided us. So position statements are another thing that come out of that. Now, let me just differentiate why we have both. Declaratory rulings help solve an issue to clarify things when asked. And sometimes we have to do a declaratory ruling because there has to be requirements that we have to put in it's a requirement. So it's a ruling, if you will, and it means it's mandated. If you're going to be an advanced practice respiratory therapist, for example, these are the things that you have to do. With position statements, not so much, but it gives sort of an overall arching view of how the board sees it. For example, we can't dictate staffing levels, but the position statement provides a lot of detail about how staffing should be handled, and a lot of research on it, and puts the onus on management as well as the therapist to be aware of what their responsibilities are. So, but it isn't a ruling to say, because it doesn't necessarily have the same weight as a declaratory ruling, but it just sort of broadcasts how the board sees that. But we've had 25 position statements come out in the last 25 years, which is kind of ironic. But those position statements have helped clarify things such as, can a respiratory therapist become involved with vascular access? And the answer is yes. And vascular access, of course, would include PICC lines. So respiratory therapists certainly can do that if they have the competencies. So the position statement lays that out. And the reason we don't have a declaratory ruling about it is because they have their own set of standards for vascular access programs. So the declaratory ruling would be used for something when there's not that standard, for example. We have multi-skilled care practitioner. Again, there's not a particular ruling on that, but we developed it into more of a position statement because it doesn't necessarily require the level of scrutiny that a declaratory ruling would provide. But nevertheless, position statements are still valuable to practitioners that you need to be aware of. So we have the AARC, and of course we have the NBRC, and that of course is where you're going to be earning your credentials through the NBRC through their testing mechanism. Now, they also have initiatives that you need to be aware of, but as I mentioned, one of the biggest things that they do is testing. And the testing tests your competence, but it also ensures for us as a board that we can license you because you have that minimum level of competency. But remember, it's minimum level of competency. It is not that you need to stop your education. But in 2024, the NBRC started investing heavily into recruiting more respiratory therapists. And they invested $4 million in scholarships for more than 450 accredited programs in order to get more respiratory therapists. Their drive for more RTs is extremely important for us as a board because we need more RTs, and we get calls all the time, emails, wanting more staff. So it would be, the NBRC is such a great organization when it comes to developing competencies. It's almost hard to overstate it. I mean, I would love to go in much more detail about why not only should you maintain your credentials because it's required by law, but why you should be proud of those credentials, because the NBRC leads the way in credentialing. The basis of over 100 other professional testing is based on the NBRC testing methodology. And that's something to be very proud of. So other professions have looked to the NBRC for guidance, and they've provided it. So they also participate in national community-based initiatives, funding research, providing scholarships, and offering expertise at forums and events to elevate the respiratory care profession. Now, they're a credentialing body. Why do they do this? Mainly because it helps the profession grow as a whole. And they are experts in competency, and competency goes to each one of these aspects. So there's a collaboration between the AARC, COARC, and NBRC. They've led a national campaign to raise awareness about respiratory care profession, which again raises your professional advocacy, and get on board with that, because being an advocate could mean just talking to someone about how you feel about the profession and maybe recruiting someone. But focusing on improving recruitment and retention of respiratory therapists. It's all of our jobs as respiratory therapists to help retain our fellow colleagues. So many people get burned out because they lose focus. One of the reasons they lose focus is simply because, well, you'll find out over time that, life happens. Step back for a moment and realize that, there is no profession that is perfect, and we are not perfect. But at the same time, we are a profession that is still growing, and that's exciting. And there's a lot of opportunity, even if at first glance you don't see that. To advocate for your profession, we talked about a lot of things so far, but one of the things you can do is simply get a higher degree. Get that bachelor's in respiratory therapy, the master's in respiratory therapy, and hopefully the APRT, the advanced practice respiratory therapy designation, which is coming in 2026. If you're not aware, UNC Charlotte has been approved to offer that program. That will help recruitment and retention of respiratory therapists, but hopefully it'll give you a goal to work towards. Now, the NBRC maintains our rigorous credentialing standards, offering the certifications, as we mentioned. Our CRT and RRT are obviously the two that you'll earn first, but they have specialty credentials, and I would urge you to do that. But let me say just a quick note about the CRT and RRT. The RRT is required for all advanced procedures within our declaratory rulings. So make sure that you can get licensed with your CRT level, but make sure you earn that RRT, because that's going to be necessary to do things like ECMO, conscious sedation, transport, all of those things that are followed within the declaratory rulings. Don't stop once you get the CRT. Get that RRT. And of course, next year they're coming out with a new exam, so you won't have to take the Clean Sims. So hopefully everybody will have their RRT, and you could do some of those advanced procedures. So next stop is COARC. Now, COARC serves an important standard, bearer of a standard, which is our education, both accreditation and holding up those standards. You would not be able to take your boards without a rigorous COARC standard. Most people think, just another agency that's taking somebody's money. Well, they don't take your money; they take the school's money. And the important thing about them is they establish those standards. If you didn't have the standard, you wouldn't be a profession. They provide recognition for those educational programs, so that elevates the programs. And then the NBRC or the schools, the programs themselves, must integrate competencies outlined by the national board in their exam matrix as part of their curriculum. So the cohort really ties the education to the credentialing, but it also says you have a valid level of education. Now, what's interesting about cohort is that they're one of the, I guess, standard bearers for outcomes-based education, and this is in a good way. In other words, they've set the standard for high educational standards, and again, a lot of professions come to cohort to get help with their standards. I'm very proud to say that respiratory therapy has set the bar for both credentialing and accreditation, and of course, we're doing that with licensure in North Carolina. So all of this feeds back into each other. The scope of practice, cohort scope for respiratory therapy includes case management, initiating treatments, managing life support, evaluating and monitoring patients, and modifying therapy. And then has the clinical training requirements which feed into that. That then again feed into the, how the matrix is designed and feeds back into how licensing, how we can approve things at the licensing level. And of course, there's federal and state regulations. Now, I don't want to get too deep into this, but only because there's a lot of this. I think if you know the first part, that's really how you can be an advocate for the profession. This part is interesting for me because if you call me up and ask me about, I hear respiratory therapists are going to be replaced by, a CMA or a paramedic. I'll pull this law out and show you that the Code of Federal Regulations says, okay, if the hospital is going to have respiratory care services, this is what must happen. This is just part of that law. It also states that staffing numbers shall be determined by the types and complexities of service offered. The director shall provide for the availability of trained respiratory technicians, certified respiratory therapy technicians. Now, this is old language, but that's what it states. Registry eligible or registered respiratory therapists needed for the scope of services offered. It does not mention CMAs. It doesn't mention CNAs, and it does not mention paramedics. I pull out these two laws, put them together, and people will back off and say, well, I guess we can't do that. Well, why is that? Because federal and state law says this is what respiratory care services must have. So we're all the way back to this list of things that we started with. So we got everything from the Practice Act all the way down to the final decision that all are interplaying. And now I don't expect you to memorize any of this. I just wanted to give you an overview of how all these things interconnected. It's not just happenstance. It's methodical. We look at every detail. We have committees. We have the board rulings. We have attorneys look at it. And everything that we do to make sure that we're making the right decision for whatever question that comes our way. The answer to those questions ultimately impacts you as a professional, and impacts the profession secondarily. So I want to encourage you to get out there, go to a conference every year, make sure that you understand that respiratory care is much more complex than simply saying, well, I can do, aerosol therapy, CPT. There are a lot of things that influence what I do as a respiratory therapist. And you have value, and the government, both state and federal, have recognized that. Sometimes you will come into contact with people that think otherwise. Don't let the naysayers get to you, because there is plenty of statutory law to say, hey, you're a professional, and we require this. We require those things of a hospital, if they're going to provide respiratory care services. There are legal factors, regulatory standards, professional standards, the patient's needs, and organizational factors that all have to come into play and do come into play. So if you ever have a question about can a respiratory therapist do something, reach out to the board. Most likely we've answered the question, but if we haven't, we'll answer it. And sometimes we, have to say, well, that doesn't fall within the scope. But most of the time, because the question has been asked, we will be able to find the answer to every single question. It may not always be what we like, but most of the time it is. And I hope that in the future, you consider, what will the future of practice depend on? And I want you to imagine the future. It's not that far away. It's tomorrow. It's the next day. It's the next day. It's the next day. In the next 25 years, you'll be probably retiring, maybe 30 years, depending on, how long you want to work, what's your age, what's your family situation. But what does it really depend on? It depends on you, the respiratory care professional. Doesn't depend on me. It depends on you. If you want to advance the profession, come to conferences like this and practice talking to people, engaging with people. Get off online courses, go to a conference hall, get in the mix. You'll be surprised at what you will find. Go to an AARC conference. I would highly encourage that. At the very least, go to a state conference. The energy levels at those conferences can be off the charts, and it will excite you about the profession. It does me every time I go. So I would highly encourage that. So that's all I have. I want to thank you for attending, and hopefully I will see you around Wilmington this weekend, or at least Friday. I will be there Friday. If not, I will see you some other time. Thank you very much.